Hello, Kidney Warriors. James here from Dadvice TV, your online kidney health coach. And this is Dadvice TV Live, episode number, believe it or not, 272. So there are 271 other videos helping you learn about kidney disease, learn what you can do to take control of kidney disease, manage it, and hopefully stop its progression or at least delay the need for dialysis. And that's exactly what we're going to be talking about today. Now, my guest is the author of what I 100% believe is the best book out there for kidney disease. And when I was diagnosed with stage 5 kidney failure, GFR 8, I wish my nephrologist would have said, hey, don't panic. Here's this book. Read it. It's an easy read. The book is called Learn the Facts About Kidney Disease. And anyone out there who's new to kidney disease, this is the book you need to read. It's going to help you. It's going to help with anxiety. You're going to learn what really matters, what you should focus on, what you can control, and you're going to learn a lot about when not to start dialysis so that you're not starting it too soon. And we're all worried about what the heck should I be eating? It talks about what's the right kind of diet. It's called a SMART diet, and it'll help you figure out what you should be eating and what you should be limiting or avoiding in your diet. And that's who my guest is tonight, the author of that book, Dr. Steven Rosansky. So everyone, please give a huge welcome to Dr. Steven Rosansky. Hey, Doc.
Hey, James. Great to be on your show as always. And hi to all the viewers. I guess you want me to introduce myself?
Yeah, because we always have new viewers here, and we need them to know why what you say matters and isn't that woo-woo that the scammers are out there pushing on kidney patients.
Yeah, so I am a kidney specialist, retired from my job. I started the kidney program at the VA, Columbia, South Carolina, and the University of South Carolina School of Medicine. And I've published a lot of research work on kidney disease, and I've taken care of thousands of kidney patients in my over 40 years of experience as a kidney doc. And a lot of my research has been widely recognized, and especially in the area of things that relate to progression of kidney disease and the issue of when it makes sense to start dialysis, which we'll spend some time on tonight because that's a really important question. And that's one of the reasons, actually, that I wrote the book that James mentioned. And yeah, so James, we'll just, and by the way, I've got over 100 publications. They're peer-reviewed. This is real science, and I highly encourage all of you to look through all the Dadvice shows. They're really good. I've seen a bunch of them, and James has some quality people on it, and I give James a lot of credit for putting this information out there for you folks to get the real facts, the real science about your kidneys, and not get you to be fearful and just buy something that you don't need and waste your money on things that don't work.
Yeah, and for me, this is like free advice that I'm getting from so many great doctors. You know, I've got my doctor here, but it's just someone who's local. They haven't published anything. So I'm always excited. I'm like, yay, look who I got on again. Dr. Rowe, I got Jen from Plant Powered Kidneys. I'm getting free advice for myself. And this type of information is what helped me go from, sitting there in the ICU with a GFR of 8 to today, floating around the low 30s, feeling great and eliminating all of my symptoms.
So today, James, I'm going to talk about, as we talked about in the title of this, when your creatinine levels are up, what do you do about your kidneys, and how do you avoid dialysis? And when is dialysis even something to even think about, which way too many people think about and are told about way too early. Mm-hmm. So the commonest worry of so many folks that come up to me, and they're mostly going to be folks that are watching the show, and like I'd say the average patient watching your show has probably got Stage what, James? Stage
Stage
1, 2,
3.
3, 4, 5. Probably stage 3. And we're going to talk about why stage 1 and 2 are not real kidney disease in just a moment. So stage 3, what is that? That's that eGFR number of 30 to 60 in that range, okay? And so I can't tell you how many older folks, and I'm an older folk myself, I'm 76. People say, what's an older folk? Well, it's usually 10 years older than whatever age you are. But at any rate, I accept that I'm an older folk. So what do you think is the first thing that you would tell somebody who's a new CKD patient, told they got CKD stage 3? What would you tell them as the first thing to get them not to worry? What's they worry about, doc, I'm going to need dialysis. And what would you tell them, James?
Well, first of all, I would
3.
say, don't worry. You need to learn about kidney disease. There's, we need to look at how much protein you're leaking in your urine. There's things that really help us indicate if you're going to have future problems. But very few people at stage 3 end up on dialysis. So let's focus on what we can do to stay at stage 3.
You hit the nail on the head. Roughly 1 out of 1,000. This is rare that you're going to need a transplant or dialysis if you are, especially older folks. And as we're going to get into in a minute, a lot of you older folks don't even have CKD. So, and too many of you have been wrongly diagnosed. And even more importantly, far too many older folks, and this is going to be for you listening, if you're an older folk like me, or if you have a parent or a friend or a relative that's an older folk that's got kidney disease, don't let that person wind up on dialysis when they don't need it. And we're going to dig into that today a little bit later. So what are these things that we talk about? We talk about creatinine. We talk about eGFR. And I apologize for those of you who are regular listeners, and I assume you know what we're going to say right now. So, James, creatinine, isn't that a dangerous substance? Isn't that something that's going to kill you? Isn't everybody worried about their creatinine? My creatinine's up and it's going to kill me?
Well, everyone is worried about it when they have kidney disease because the internet makes it sound like it's the problem and it's bad for you. But and it was hard for me to accept that it's normal. It's from your muscles. My doctor told me, if you want to really lower your creatinine, amputate your legs so you have less muscle. But that's not going to help your kidneys. You're just going to be in a wheelchair now.
Yeah. So basically, James hit it on the head. What happens is, depending upon your muscles, every day a bit of muscle breaks down and it's metabolized in a normal process into a substance that's called creatinine. And guess what? Creatinine has nothing to do with being a dangerous thing. It's nothing to do with a dangerous substance. It's simply a marker. It's a convenient marker in your blood that allows us to calculate something called eGFR. E for estimated GFR. It's not the real GFR, by the way. It's just an estimate. And the people, the various labs that get your creatinine levels, they will calculate the eGFR. And I followed this for decades, and I can't tell you how upsetting it has been to me because of my academic colleagues keep coming up with new equations. They're trying to get rid of the race in the equation. They're trying to come up with a better equation that's going to be, give you more exact data. There is no exact data. It's just basically getting my colleagues to publish more papers, I mean, these are just an estimate, no matter what equation you use. And the problem with a lot of labs is they've changed the method that they use to determine creatinine. They changed the different method they use to calculate eGFR. And this data gets so confusing. Because the data is so confusing, and let me tell you, for example, even though I'm retired, I go to the free clinic. Went to the free clinic today, and I'll tell you about a patient that I saw that is so common. This patient had a couple, let's say a month ago, 2 months ago, their creatinine was 3.4. Today, it was back down to 1.9. And I looked at the creatinines over the last year. They bounce all over. You may well be one of these people whose creatinines bounce all over. And especially when you're getting into creatinines in the higher level, like 60 or above, they're totally inaccurate. And in order to diagnose someone really having CKD, because I get people, oh, I went to the doctor, my eGFR was 45 or 50, and I'm worried I'm going to be on dialysis. What does that patient need to know, James, after that first creatinine that they got abnormal and they're worried?
Well,
Do they have
first of all,
CKD?
that they do not have CKD unless there's other symptoms. But they need to get another test in a few months to verify and to see where they are, because that eGFR, it fluctuates because it's an estimate based on how much creatinine is in your blood, and they may not have it. They may be dehydrated.
Right. And the official word of the kidney experts is that, and they found out exactly what James said. These numbers bounce all over. I can't tell you how often I see this. It's so common. The quickest way to cure your kidney failure is repeat the lab.
There you go.
I can't tell you how often that happens. And the kidney experts have decided you don't have kidney disease until you've got at least two values 3 months apart that are abnormal. Okay? That's the first thing you need to even be saying that you got CKD. And the other thing that James knows well, and we just kind of mentioned it as an aside, is don't get hung up on any one value. Mm-hmm. You've got to get the data, and that's what I do. I look at all the data on my patient, and I look at the trend. And if there's no trend, I don't worry the patient.
You're stable.
You got to look at all the data to see if your creatinine's going up, which means your eGFR is going down. Creatinine going up means eGFR is going down, because creatinine is in that equation. Mm-hmm. You remember from your math that that's in the denominator. The higher the creatinine, the lower your eGFR. So the equation takes into account your creatinine, and we're going to tell you what else it takes into account. And here's something that's important as far as creatinine levels. A lot of you folks are going to have creatinines that are close to the normal level. So let's say the normal level is actually a fairly wide range, depending on the lab. So say 0.6 to 1.2. And let's say your creatinine went today from 1 to 1.2. That's a massive change in eGFR. That's a 20% change in your creatinine, which is going to have a 20% change in eGFR. So it's a useless eGFR when your creatinines are close to normal. And because of this, what are some labs doing, James, when they get eGFRs above 60?
They're just saying above 60. They are not giving you a number because it's not something to worry about unless you have other symptoms, and it's so inaccurate.
Exactly. And so they say over 60, okay? Now, the next issue, which James knows this very well, is another thing that people haven't really focused on enough, is that in the equation with eGFR, we put your age in the equation. Why is that? Why is that, James? What happens as you get older?
As you get older, your kidneys naturally go down in function, so you're automatically having more creatinine in your blood. And even with the age now in the formula, I don't think they do enough to talk about the role age plays.
Okay, let's clear this up.
Estimated GFR is.
You're mixing up a little thing, so let's clear this up because this is important. So the thing to remember is that with age, we lose muscle mass, okay? You lose muscle mass as you age. And one of the most important things for you to do to decrease your risk of dying of a heart attack and stroke and so forth is exercise and try to preserve your muscle mass. So as you lose your muscle mass, we have to adjust for that in the equation. So I'll give you an example. and basically, we do lose about 10 units of GFR per decade over 40. And that's after correcting for the muscle mass. So let's say your creatinine is 1.5 and you're 50. Your eGFR, the lab would give you a 56. If you were 80, same creatinine, the lab would give you an eGFR 47. Okay. And so that's correcting for, the muscle story. But then we've got another story, right?
Mm-hmm.
So let's say you're 80 and you have an eGFR 47. Are you going to say, oh my goodness, I need to go on dialysis, I need to worry, 47, that's terrible? What do you say to that, James?
See, this is where age plays another role. You
Right.
may be close to normal for that age.
Perfect. And I admire my colleagues in Australia and New Zealand, and they have guidelines. We don't have this, which we should, which says if you're over 70 and your eGFR is over 45 and you do not have significant protein in the urine, and we're going to dig into that. What is significant protein in the urine? That is crucial. What Australia and New Zealand docs say, your eGFR is consistent with your age-related decline in GFR. You expect GFR to decline with age. So if you don't have significant proteinuria, you don't have CKD. They say over 70. I don't know, maybe that's a little young, but you get the idea. Don't be panicking if you're 70, 80, or 90 and you got an eGFR around 50, which, by the way, I'll say this right now, because it is such a variable result, it's going to be plus or minus at least 10% or maybe even 20%. So if it's 50, 10% of 50 is 5, right? So your real number may be 45 to 55. Don't get hung up on any one number. I like what the UK people do. We don't do this in the US. I think part of it may be because we have too much fee-for-service medicine, which I won't get into tonight, but we certainly could at another night. What they say is no CKD if you're over 64, except for those who have, no CKD if eGFR is over 60, right? We just said that. Well, they don't even report it over 60. But let's say it's over 60, when would you call it CKD? If there is significant what?
Protein in the urine.
Proteinuria. Okay. Now, this is so darn confusing. What is significant proteinuria? And I will admit, because I've been in this business over 40 years, and there's been a lot of confusion about what is really significant proteinuria. There's something called microalbuminuria. You may have heard that with your doctor. They used to have these dipsticks for microalbumin. It turns out, and I did research studies using microalbumin, it is not a reliable indicator of kidney disease. What is microalbumin? What is non-significant proteinuria? If you are never more than trace on your urine, that's not significant proteinuria, okay? Significant proteinuria is when your doctor takes a spot urine, takes a drop of urine, sends it to the lab. The lab will measure the albumin in the urine and the creatinine in the urine, and they'll get a ratio. And in the U.S., if the ratio is over 300, that's significant. I would even say over 200. I go with 200. 300 for sure. I'll even take 200 for that ratio. If you're outside of the crazy U.S. units of measurement, divided by 10. So you're outside the U.S., it would be either 30 or 20. In the U.S., 300 or 200. That's milligrams of albumin per gram of creatinine. And in the rest of the world, we go for millimoles of creatinine. Don't ask me what a millimole is, because that's way too confusing. So again, so many folks worry about their urine protein that's trace. That's say less than 200 a day of albumin, maybe 100, 150 a day. Why is that? Why is that not significant? Because it varies a lot. Just like your creatinine varies, this varies a lot. if you got fever, if you've exercised. And it was a study done, and they took a large group of people that had this non-significant protein in the urine. They checked it again a couple weeks later, it was gone. So just like with creatinine and eGFR, you need to look at data over long periods of time to see what your trends are, okay? And again, over 300 for sure, albumin to creatinine. I'd even say over 200 is significant. And again, divided by 10 to get the numbers from the rest of the world outside the US, okay? If you've got 1 plus or more consistently, significant protein in the urine. Certainly 2 or 3 plus or more, way significant protein in the urine. That's a real concern. Go back to the Dadvice talk on proteinuria. A lot of you may have seen it. It's been widely watched. It's a very important talk. And we gave several talks related to the proteinuria and several drugs that affect it. Please go back and listen to them. Why, James? Because proteinuria is the best predictor of what?
Of future kidney issues and going on dialysis.
Of decline in GFR. Yeah. Absolutely right. The level of your proteinuria is the most important determinant of whether you're going to lose your GFR over time. And the main goal, and that's what I discuss in detail in those Dadvice programs, the main goal for you folks that have significant protein in the urine is to reduce it with various ways that we discuss. And this is the best way to slow the loss of your kidney function. Critical. And listen to those talks. But way too much emphasis on that eGFR number. Mm-hmm. A few units of change of the eGFR number. It is meaningless. My eGFR went from 50 to 45. It's meaningless because, as I said, a 50 could be a real number of 45 or 55. These small changes don't mean a thing. Okay.
See, the problem, or part of the problem is the kidney patient, we go, we do some looking. The doctors are talking about dialysis. So we're researching dialysis, and it all talks about creatinine and eGFR, and it makes it sound like creatinine's the problem, and that if we could just get rid of it somehow, just a magic pill. You know, there's some flour on the eastern side of some mountain in Vietnam. If we just could get that flour and consume it, our creatinine would be fixed and our kidney problems would go away. That's kind of what happens. We get stuck in this mental loop looking for that, and then the scammers are out there making it sound like that's how you fix kidney disease.
And the scammers are going to tell you. And the scammers are going to tell you, they're going to sell you books. They're going to sell you all kinds of kidney cleanses or kidney potions. And they're going to give you all these stories about somebody who went, as I just said, let's say from 50 to 45 or 45 to 40 or, you know, and look at this. This is for, again, most of this is not real. It's just the way the numbers go with eGFR. Unless you're looking at the studies that I've talked about. I talk about the drugs that really work to slow decline of kidney function. I've talked about them ad nauseum, the ACEs, the ARBs, the SGLT2s, the GLP-1s. Mm-hmm. Dig into the prior episodes and you'll get a lot of detail on that. So most of you folks that are older, and most of you folks even that are younger that are listening to this are probably CKD3. And a lot of you folks that are even CKD4. What's CKD4? If you're an older folk, CKD4, right? CKD3, 30 to 60. CKD4, 15 to 30. There are people with CKD4 that could have stable GFR for years, even 10 years. And there's a good reason for that. James, do you know the reason why older folks as opposed to younger folks older folks don't lose their kidney function as quickly? Do you know the main explanation?
I do not.
Okay.
Or I cannot think of it if I know it.
That's fine. The main explanation is that older folks rarely have high levels of urine protein. They rarely have high levels of urine protein. Much more common in the younger folks, okay? And again, if you're an older folk with 45 or more, no significant proteinuria, maybe not even CKD, all right? So what if you're one of these older or younger folk with eGFRs anywhere, below 60, let's say 30 to 60, no significant proteinuria? What should you be focusing on?
Managing my blood pressure, eating a heart healthy diet, getting some exercise, anything that helps my heart.
Absolutely, James. And we've said this, I'm sure, a dozen times or more, that when you're dealing with non-significant proteinuria, especially CKD3, the real reason to know that you even have an abnormal eGFR, abnormal creatinine, is it's a risk factor, like having high blood pressure, like having high cholesterol, like smoking, like being obese. It's a risk factor for getting heart disease, for getting strokes, for getting trouble with blood flow to your limbs, etc. So it's a risk factor, and you need to do everything to lower your risk of having one of these bad events in your heart or your brain, for that matter, which James knows all the stuff, and we've talked about this in a lot of other podcasts. You need to get rid of the cigarettes. You need to get the goal blood pressure. You need to exercise, 30 minutes at least 5 times a week, and to get your cholesterol down, be on a cholesterol drug. All of you with CKD should be on a cholesterol drug, and get your goal bad cholesterol, I would say below 60, with enough of the cholesterol medicine. So it's a risk factor. It's a risk factor for getting the thing that James and I talk about, atherosclerotic cardiovascular disease. Big mouthful of stuff, right?
Thank you for not making me try to say it.
So atherosclerosis, hardening of the arteries, right? And again, if you got non-proteinuric abnormal eGFR, you're at a risk of getting one of those bad events, atherosclerotic cardiovascular disease. So there's 2 parts to the kidney story that will increase your risk. The one is the level of your GFR. The lower, the higher your risk of getting one of these bad events. The other thing is the level of protein in your urine. So not only does the level of protein in the urine put you at a higher risk to lose kidney function, but the 2 of those things put you at a higher risk of the mouthful, atherosclerotic cardiovascular disease, bad strokes, heart attacks, chest pain, angina. And which of the 2 is more powerful predictor of getting one of those bad events? What would you say? The GFR level or the protein level?
Protein.
It is. You're right. How do you like that? And the 2 of them together. So if you are a patient with an eGFR, let's say less than 30, and you got a good bit of protein in the urine, not only do you need to be concerned about whether your kidneys are going to fail, but you need to be concerned about preventing a heart attack or a stroke, because you're at a higher risk, okay? Now, what about some of the diagnoses that come along with kidney disease? Up to half of you diabetics out there may well at some point be told you have kidney disease. So if you happen to be one of these diabetics, told you have kidney disease, what about your A1C? Should you be getting your A1C to 7 or 6.5? Yes or no, James? And especially if you are...
It depends. Where is your GFR?
Okay.
There's the answer.
Well, okay. I would say this, James. It really has to do with your age more than even your GFR. If you are over 70, first of all, a lot of people don't. When I was just talking about ways to decrease your risk of heart attacks and strokes and those other bad events, I didn't mention getting tight blood sugar control, because unfortunately that hasn't been proven to actually decrease those bad events, although most people assume that it will. And there's way too much emphasis on getting your A1C to less than 7 or less than 6.5. If you are an older folk, 8 is what you should be shooting for, because hypoglycemia is much more dangerous. It could lead to seizures, strokes, heart attacks, falls, breaking your hips. I mean, low sugar can kill you. It's a much higher concern than a high sugar if you are, let's say, over 70. Shoot for 8. If you're a young person, 30s, 40s, maybe 50s, maybe then you could shoot for 7. Okay, but you got to be careful.
50
with
is young.
There you go, a young 50. Because there may be some benefit there, but certainly very young. Yeah, shooting for tight sugar control, very young. But you're right, James. As your kidney function goes down, the risk goes up. So if you're an older person with decreased kidney function, you are at a especially high risk to get dangerously low blood sugars. So be careful. What about blood pressure?
Oh, very important.
Goal blood pressure is another important factor to decrease your risk of kidney progression and decrease your risk of bad outcomes from heart and brain strokes and heart attacks and that kind of thing. And if you're younger folk, shoot for 120 or less. I'm good with that. If you're older folk, you may want to be a little less aggressive. 130 to 140 is probably okay, because older folks have a tendency to get low blood pressure, to fall, to get fractures. And if you are experiencing dizziness, hold your blood pressure medicine until you check it. And if it's low, hold that dose. Okay, I'm not going to spend a lot of time on these tonight. Let's move into, before we're going to spend most of the discussion on dialysis and choosing when to do it and who really should even be considering it. Before we get into that, let's talk about AKI. Tell folks what AKI means, James.
An acute kidney injury, and that means temporary. And the number one cause of AKIs is dehydration.
James, you're on it tonight. You're absolutely on it. So AKI, think about, you go to your doctor and your eGFR is 50. You go back to your doctor and your eGFR is 20. Well, that's acute change. That's a large change in eGFR, a change of, let's say, 20, 30% or 50%. That's what we call AKI, okay? And unfortunately, and James knows this, too many folks go in the hospital, and James was one of these, that had a AKI and their kidney function temporarily declined to levels that doctors will put you on a machine. It's a business. I gotta be very frank about it. It's a business, and if somebody's got abnormal kidney numbers, you put them on a machine, and it's a lot easier to manage for the doc, but not a good idea for you unless you need it. And if you're one of these folks that kidney function got worse over a short period of time, say, hey, doc, can we see if my kidneys are going to recover? Do I really have to go on? Is this an emergency? Because in a lot of cases, they could recover with things like James just mentioned, simple thing like giving you IV fluids, hydrating you. And the best way to prevent it, as James said, is, especially when you're on the drugs for significant proteinuria that can decrease the proteinuria, and they are, rattle them off, James. Give me some names. The drugs that decrease proteinuria, and they can
ACEs
also,
and ARBs. I just don't remember what the names of them are.
Okay, and then the SGLT2s, which we discussed in the prior talks, and the GLP-1s. So all of the drugs that have good benefits to slow kidney function decline, if you get dehydrated, they can especially cause an AKI. So be careful. And we don't stop these drugs unless there's at least a 30% decline of your GFR and it's not getting better. because these drugs are so important for those folks with significant proteinuria to slow the decline of kidney function. Okay. I don't have my watch on today. I'm just seeing. So, okay, we got
35 after.
Right. Okay, we got plenty of time. All right. So now we're going to dig into a really important topic, and a topic I'm passionate about, and James knows this: how to avoid dialysis, especially how to avoid early and unnecessary dialysis. What do I mean by early dialysis? In general, over 10 eGFR. That's the range, over 10. That would be considered early. And I've done a ton of research on this and published a lot of papers. And if your doctor's starting to talk to you about high creatinine and lower GFR, and hey, maybe we got to get you ready for dialysis, please read my chapter on when to start dialysis. And just as a ballpark figure, the research, and many people's research, my research, a lot of my colleagues' research, has shown the most beneficial time to start dialysis, not for everybody, but for the majority of people, and you got to take everybody's an individual, and there's a lot of individual issues that need to be considered, is at what level of GFR? 15, 10, what would you say, James?
5.
5 or less, exactly. And so few people ever get near 5 before they're already on a machine. The research has shown 5 or less, not for everybody, but that's just at least something to consider. And again, look at my book, I reference everything, and please discuss it with your doc. Far, far too many people, too many of you folks, too many of your friends and relatives are starting over 10. And way, way sad is so many over 15, starting at eGFR over 15. That to me is really sad. Really, really bugs me. And if your kidney doctor is saying, well, I'm thinking about dialysis for you, there's things that they should be talking about that they may not be talking about. There's something called informed consent. You know what informed consent is, James? You want to tell your audience briefly what that means?
Is that the one where I decide somebody who makes decisions for me? In case
Well, whenever you go to a
is that what that one
hospital, if they're going to give you a treatment of any significance, like dialysis, like a pacemaker, like surgery, like anything that anything they're going to do to you, any kind of procedure they're going to do to you, they need to give you a risk-benefit analysis. That's giving you information to get your consent. By the way, just because the doctor says something, you don't say, oh yeah, doc, do this, anything. Not smart. Educate yourself. And your doctor should give you an informed consent, which talks about the good and the bad of anything they want to do for you. What's the benefit? What's the harm? You got to get informed consent. And one thing that is crucial, especially if you're an older person, especially if you've already had multiple hospitalizations, you've had heart failure, you may have had a stroke, you may have had a heart attack, you've been sick, been in the hospital a lot. They don't tell you about what's your likelihood of surviving and how long. And you want to know this. And my book goes into ways to predict, if you start dialysis, what's your likely length of survival. So you could get a handle on that. Real disturbing thing, and what we talked about earlier, older folks, nursing home patients, there was a study done by one of my colleagues. Almost 1 in 5 of the people in this study started above 15 eGFR. And guess what? Few of them had a good reason to start. Don't let this happen to you or anyone in your family. So informed consent, your doc should tell you what are the downsides of going on dialysis. A lot of people say, oh, dialysis, this is going to be great. I got a kidney problem, so I better go on dialysis. No, 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 no. Dialysis is the absolute last resort. What are some of the things that you got to expect if you're going to go on dialysis? You can get functional decline. You can get less brain function, especially older folks. A lot of folks feel really washed out after their dialysis treatment. Dialysis is going to take up, if you're an older person, your 80s or 90s, it's going to take up an enormous amount of your time. And that's why I recommend highly doing your dialysis at home and doing peritoneal dialysis. And that will be another talk for some other time. The various choices if you have to go on a machine. The other real bad thing that happens when you go on dialysis is you lose your own kidney function. And as much as we got fancy ways to dialyze you with fancy machines and different dialysis techniques and different numbers of hours on dialysis and dialyzing you every day and all kinds of crazy stuff, which I, by the way, I'm totally against. Daily dialysis makes no sense. Again, that's for another show. You lose your own kidney function. And the only thing that's been demonstrated to really improve your survival is your own kidney function. We have not been able to demonstrate that dialysis itself improves survival, which is crazy. So when you get low enough, yeah, you're going to have to go on a machine to stay alive. But it's pretty low. That point is pretty low, not 15 and not 10 or more. So what do my colleagues and I all agree? Pretty much we all agree. If you ask them, they say, well, why should someone go on dialysis? They should go on it for their symptoms, not for their eGFR number. That's not a good reason to go on a machine. Lots of confusion. And James, I got to get you straight with this because you talk a lot about symptoms. When can a patient with CKD even begin to expect any symptoms related to a lower level of kidney function? At what eGFR ballpark?
It's going to be really, it's for me and for most or everyone that I know, it's around 15 or 10. It is so low. Other symptoms I may not even have noticed because they may have been so minor at a higher GFR.
So let's break it down. I would say if you're above 30, it's going to be unlikely that anything you're experiencing, and kidney trouble is painless. You're not going to have pain unless you got massive polycystic kidneys, which is rare. It's going to be symptomless. And the only time you may start considering whether you're going to have symptoms is less than 30. James is right. 15, 20, yeah, you may well start having symptoms, but not, you're not going to have them 30 to 60. That's highly unlikely that you're going to have any symptoms at all. Don't expect it. And don't get these people say, oh, you got eGFR of 40. I'm going to fix your symptoms, do a cleanse of your kidney. Nonsense. Don't expect symptoms until less than 30. And James is probably right, probably even less than 15.
Yeah, okay. And mine came on all sudden, a cough, headache, vomiting, mine were all just, it felt like within 1 week, all of my symptoms appeared. And that was when I was in kidney failure. Before that, I was fine. 2 weeks before my kidneys were in failure and I was in the ICU, I was out doing stuff. I was active. I felt completely normal.
Yeah. Well, here's a thought, James, for your audience. Before agreeing to dialysis, unless it's an emergency, there are cases where people can't breathe, they need to get rid of fluid, but they're pretty rare. Ask your doc and say, "Hey, doc, why do you want to put me on dialysis?" And Dr. Rosansky says that most kidney doctors agree it should be for my symptoms. What are these symptoms that you want to put me on dialysis for, and can we try to manage them medically? A trial of medical therapy for the symptoms that your doctor may say they want to put you on dialysis is well worth consideration. Now let's break down the symptoms. The commonest thing and the game changer for people with CKD is symptoms related to anemia. Okay?
Yep.
And guess what? Dialysis doesn't help anemia. It makes it worse. So you're not going on dialysis for all those symptoms related to anemia, which we treat real easily with drugs called EPO. It's the stuff that your own body produces to stimulate your bone marrow to produce red blood cells. And as your kidneys fail, you get less of this substance produced. And when that drug came around, it was a game changer. People felt so much better at all stages of CKD. And again, not a reason to go on dialysis. That's the biggest one to give you symptoms, relates to anemia. The other thing that people may have is fluid overload. And often that's not a result of kidney level issues, not your eGFR, but it's related to heart failure. So a lot of the symptoms that people may think they have to be dialyzed for are not kidney related. They could be heart related. You need to get your heart doctor to give you enough treatment for your heart failure, get you enough water pills and so forth. But there are some folks that will have fluid problems that can't be managed. And I'm very aggressive with my diuretics, a lot of water pills. A lot of kidney doctors don't use enough, in my opinion. So that's a reason to go on. You can't control your fluids, especially if your urine output's dropping. I think then you got a definite reason to go on. The other one is potassium. And sometimes potassium levels are hard to control, but there are some good drugs even to control potassium. So all of the usual things that are good reasons to consider dialysis can be managed without the machine. But get this, most of you folks that go on dialysis early are not going on for the reasons I just mentioned. The reasons why docs give their patients that they should go on dialysis are, well, it's basically your eGFR. And they can, because there have been guidelines over the decades, and I've been real involved with these guidelines, that they were saying, oh, over 10, maybe start you, maybe even over 15. They have revamped these guidelines due to my research and research of my colleagues, and they're saying, no, don't go on the basis of eGFR. Go by what your symptoms are. And what the symptoms that people get started on, they're non-specific. I feel a little tired. I feel a little decrease in my appetite. And that's one of the commonest things. They say, well, I don't feel as hungry as I did. And, I'm not saying that dialysis can't help that. Dialysis may improve your appetite. That's possible. But by and large, going on dialysis, your nutrition is going to get worse over time. It's been shown over and over again. So dialysis is not going to cure the fact that you're losing weight and you don't have a great appetite. It's not going to cure it. It may get a little better, but it's not going to cure it. So when you are asked about the kidney machine coming down the road, we need to talk about it. You got to get informed consent, and you need to share with your doctor, with your family, about what you are interested in. Some of you, especially if you're older, you folks in your 80s and 90s, and especially if you've been real sick, you've been hospitalized a bunch, you may not want to have any more pain. That may be the most important thing. Some of you, a particular symptom may be the most important thing. Your shortness of breath or that kind of thing. I mean, that's reasonable. Or you may have intractable vomiting and nausea. You can't figure out another cause. I'm good with that. Let's try dialysis. But if you want to avoid pain, especially in your eGFR is 10 or more, it's not below 5, you may not want to even bother with dialysis, because the first thing you're going to need is an access. And if you're older, you got to get this thing in your arm. It's like they connect the two blood vessels to get the blood vessels really big to stick the needles in to go on that hemodialysis machine. A lot of older folks never get to use their access because they die before they ever need it. Because, as we discussed earlier, if you're an older person, the rate of loss of your kidney function is slow. It may be stable for a long time. Leaving out the acute kidney injury, the dehydration and stuff like that. If you stay in good hydration, you don't drop your blood pressure, you could have stable for many, many years. And just one other point of information, if you are an older person, you've been sick a lot, you've been hospitalized a lot, rather than have a lot of surgeries, and I talk about my poster child, I love this patient of mine, a veteran patient, who had 4 operations, 2 on each arm, upper and lower arm, came to me and said, my doctor said I need dialysis. Guess what, folks? I followed him for a year. He did not need dialysis. He went through all those surgeries unnecessarily. And there is a choice. If you're really an older person, you've been hospitalized a lot, if you get to the point where you say, well, doc, I'm having trouble breathing, my level is 5 or less, I'm ready to go on, they could put a catheter in your neck to use to put you on a machine. So you don't have to have those operations on your arms, okay? And it may well be the case that if you've been real sick, you've been hospitalized a lot, you've got lots of trouble with other illnesses, you may survive better with conservative management than you would with dialysis. And most people, the decision to start dialysis, the doctor talks to them months before they even start. Oh, your eGFR is such, I think we're going to plan to start you on dialysis without any real indication. No rush, no rush. Remember, your decline is going to be slow for most of you. Now, there's something called conservative management. What is conservative management, James? What do you think would be included in conservative non-dialysis management for advanced kidney? What does that mean?
Medication. You use what's available to manage the symptoms and, do the best you can. Give you a good quality of life.
Yeah, I think you described that pretty well, James. I mean, look, I have a chapter to talk about realistically putting in your information. You can go over it with your doctor. What's my survival probability? 3 months, 6 months, a year, assuming I go on dialysis. For a lot of people, this non-dialysis management is a much better choice. You get all the medical treatments we talked about for potassium, for your anemia, for your fluids. We can control a lot of your symptoms with medicines. And if you are not interested in having a lot of needle sticks and stuff, you can decrease the amount of blood drawers, and you can tell your doctor that you want to be comfortable. I'm not telling you need to stop monitoring. You can continue to monitor, and then you can always change your mind. Your doc says, hey, your potassium's up and I can't control it. Are you ready to go on? You can say yes or no. And you can always say, hey, doc, I'm ready. Put a catheter in my neck if that's what your choice is, okay? And why are so many older folks starting on dialysis early? Sometimes your family says, hey, you better go on dialysis because they don't know any better. They need to read my book too. And often it's based on the eGFR number. Not a good reason to go on. It should be your symptoms that can't be controlled medically. And the main reasons why all us docs, kidney docs, will agree to go on dialysis is if you are not making much urine, we can't control the blood volume, you're having trouble breathing, for sure. You got something like your heart's got something around it called pericarditis, inflammation, for sure. That potassium can't be controlled with medicines, for sure. You're having nausea, vomiting, you can't control it, even though you've no other reason, you don't have an ulcer or anything like that. I'm okay with that. Again, most people don't have one of those good reasons. And the last thing I'll mention before we take your questions, oh, you only have 7 minutes. Okay.
Yeah,
I guess you got a lot of questions. I'm sorry. Yeah, I'm sorry, James. Usually I give you more time. But yeah, so I would say last thing to remember, please have an advance directive, meaning let your family know if you are not conscious, do you want to be intubated, do you want to go on emergency dialysis, stuff like that. Have an advance directive. All right, well, I didn't leave you much time, and you can pick out the questions.
We got some great questions here.
Okie doke.
Maria, her GFR is 4, and she's 44 years old. She has congestive heart failure, and her creatinine is 12. Her doctor wants to put her on dialysis, and she's confused. Based on what I've heard you say, it sounds like for her, 4 is a good time to go on it at age 44.
Yeah. Well, look, again, please, if you get a chance, get my book, because I describe the choices for somebody like you. You have, if your renal function is below 5, as you mentioned, and it's stable below 5, you got to bite the bullet and consider transplant or dialysis. Now, you're 44. Because of your heart failure, you may or may not be a candidate for a kidney transplant, but that would be the first choice. The next choice would be try to inquire about doing your dialysis at home, called peritoneal dialysis. I discuss all the modes of dialysis in my book, help you make a choice. And for you at 44, being afraid of needles and stuff like that, talk about, hey, doc, can you teach me how to do my dialysis at home? And most of you folks can do that. You can do it at night while you're sleeping, and you don't have to go to the dialysis unit and take up your day with all that stuff. So yeah, I would recommend that you go on a machine at that level, and it will help manage your heart failure as well. Good
Yeah,
time
and I'll
to
tell you,
really seriously consider.
I've seen some of what's coming for improvements to the home dialysis machines. They are about to get even easier and better within the next 3 to 5 years for home dialysis.
I mean, peritoneal is very simple to learn. It's very, very simple. And I highly recommend it. Peritoneal dialysis. Check my book out. Go ahead.
Okay, Rowie says his potassium is about 5. Do they need to be on meds to lower it, or is she just fine?
You're fine. Most non-kidney doctors panic at 5. Kidney doctors would even start thinking about it being high, 5.5 to 6. So that's not a high potassium to me. The first thing to worry about if your potassium is abnormal is, are you on a medication that's raising your potassium? And talk to your doctor about that possibility. So that's not a level to get real worried about.
Very good. And here's another one that I think is a great one to answer. Kathleen is 73. Her eGFR is 58. Do you think she has kidney disease?
Again, we talked about this tonight. My colleagues in Australia and New Zealand would say if you do not have significant proteinuria, more than 1 plus consistently, more than 30 in your outside of the U.S. or 300 in the U.S., the spot urine protein, you don't have kidney disease at 58, and you're over 70. Okay, not to worry.
Very, very good. I'm looking for more questions in here. Someone said, Alicia said, why does my urine look dark yellow, then light after drinking water?
Yeah, I don't think the color of your urine is an indicator of whether it's concentrated or dilute, because there's a lot of stuff that you can eat that can affect the color of your urine. So I don't think the color of the urine has much bearing on anything, actually. Okay. All right.
Do you see any there you want to answer? We got a few moments left.
Okay. So Stacy talks about how to lower the protein in the urine. Look for my talks on proteinuria and several things to do if you've got significant protein in the urine. Decrease the salt in your diet. Get on the highest dose of an ACE or an ARB you can tolerate. Add an SGLT2 in some cases. And those would be the things to do to get that urine protein lower and to decrease your chances of needing to go on dialysis. If you're losing 26 grams of protein, Marion, you only get symptoms from medications. That's why it's difficult to understand. If you're losing 26 grams, that's crazy. And then going on max. Yeah, I don't know about 26 grams of protein. That's unusual. and when you talk about blood pressure medicines make you dizzy, very good point, Marion. As I said earlier, especially if you're an older person, if you are on blood pressure medicines and you're starting to feel dizzy, please sit down, check your blood pressure. Don't take another dose of medicine until your top number is over 130. Too many people get into trouble with decreased blood to their brain and their heart. you can produce a stroke or a heart attack by lowering your blood pressure too much. So maximum blood pressure medicines should not make you dizzy. If they are, then it's probably too low or there's some other thing going on.
Very good. All right, we are at the top of the hour, Doc. Thank you
Okay.
so much for sharing this information. Always a pleasure to have you here. And for those out there, we've mentioned Dr. Rowe talks in more detail about many of these topics and other things that were not discussed here. If anyone out there would like to get a copy of his book, go to your local bookstore, or you can go to the link go.dadvicetv.com/book, and that will take you to his book, Learn the Facts About Kidney Disease, on Amazon. It is a super duper easy read, full of great information. And if you're like me, you are worried, scared to death, didn't know what to do, it helps so much at relieving that anxiety and that stress and that worry. I cannot stress enough how well it will make you feel. You will read the book and you will agree with me. Every diagnosis of kidney disease, they should hand your book out and say, hey, don't worry. Read this and be careful what you see on the internet. Because there's all sorts of stuff out there. All right, Doc, thank you so much. The Doc and I will be back again next month. We'll post on Facebook when the upcoming show is. I'd like to thank all of you out there for joining us. Please subscribe to Dadvice TV on YouTube. Like and share this video. It really helps me to see people are sharing this information, getting it to more and more people. All right.
And
Oh, yeah.
One last thing, James, again, I've asked last time, and I get really joy out of it. Any of you that have avoided dialysis, that have delayed dialysis, or maybe waited too long, I mean, it could be both ways, please send a note to Dadvice, and I'd love to hear about it.
Yeah. Go to dadvicetv.com, and there's a contact me form. You fill it out. It'll come to me, and I will send those over to Dr. Rowe. And it's great to hear from everyone out there, because all of us are helping support each other, educate each other, and educate others out there who have kidney disease. So we're having a better quality of life and not worried so much about things that really we don't need to worry about. All right. Thank you all. And I'll see you all in the next video. Bye, everyone.
Bye.